The Augustus trial, we'll be talking about dual therapy versus triple therapy, in addition to the great trial that was Octavian, Augustus, and the succession of the politics of Rome. So here's the overall takeaway from the Augustus trial. We're looking at antiplatelet and anticoagulation choices in people who have ACS and AFib. And here's the overall takeaway in case you don't want to wait for the end. P2Y12 inhibitors and apixaban was better than triple therapy, though we'll see that in the trial itself, essentially the choice of P2Y12 inhibition was over 90% clopidogrel or Plavix. Um, you have decreased bleeding as one of the primary outcomes compared to triple therapy. Um, and obviously less bleeding with P2Y12 over aspirin and overall fewer hospitalizations. So the history. You have to remember that prior to the Augustus trial, there was a tremendous amount of uncertainty about the future that was stemming from lots of instability. In both cases here. Rome's borders were being threatened because of this instability, because of all this uncertainty in the air. Things could not last for much longer. There had just been a bloody civil war just a few years before, and people did not want to go back, but did not know how to proceed. It had been shown that triple therapy, compared to double therapy, in this case with dabigatran and a P2Y12 inhibitor, led to much more bleeding. But we did not know if this bleeding was because of not using warfarin or not using aspirin. So essentially, all joking aside, it boils down to we know that triple therapy with warfarin, Plavix, and aspirin causes more bleeds than dabigatran and Plavix. But is the aspirin causing the bleeding, or is it the warfarin that's causing the bleeding? And if we kind of go back here with the first triumvirate, as it was, eventually would lead to a bloody civil war. And so all this is essentially about blood. So we got to talk about the design. Augustus knew he had to look ahead to the future and not be retrospective. All right. The Roman Empire was vast and multi-centered. Look at all this. And you had two different groups involved. All right. In this sense, you have Augustus and his friend Agrippa, the famous general, and then you have the other part of the second triumvirate, Marcus Antonius and Lepidus, who was the favorite of Julius Caesar's, who kind of just didn't really do anything in this case, but I just have him here as opposed to these two. Randomization was key. And you'll see that this is also a 2x2. Randomization was key. Early on in life, Augustus and Agrippa had by chance become friends. And if the situation had been fixed to hook our Augustus with preset expectations, it really hampered the legitimacy of the results. Augustus knew that there would be two ways he would be judged during these trying times. Number one would be how much bloodshed there would be. And second, the amount of death that he would see on the battlefield, as well as ischemic events. And I'm going to go back here to just show you what a 2x2 factorial design is, and kind of what it looks like in our in our Augustus trial here. You've got a couple levels worth of dependent variables. Obviously, anticoagulation being the big one, apixaban and warfarin. And then the other independent variable is the antiplatelet therapy that you're choosing, whether you're doing aspirin at 100 milligrams. Um, I'm saying Plavix, it's really just a P2Y12 inhibitor, but over 90% of it is Plavix, and that's what's been used. Versus a placebo with a P2Y12 inhibitor, which in this case, the majority of it was Plavix. And here's what we're looking at. Bleeds, death as the primary outcomes, ischemia and hospitalizations as the secondary outcomes. Worth mentioning, this is the Battle of the Tortoberg Forest, probably the most famous battle during Augustus's reign, notable for stopping the advancement of Rome past the Rhine, really. And when I say Rome, I mean the Roman Empire past the Rhine. They were going to try and go, farther east to the Danube. Um, did not work out. You had a famous a German kind of playing a double cross as a scout and leader for the Romans called Hermann or Arminius, who kind of led them into a trap. And afterwards, obviously, you had no more advancement. So essentially, here's the question, the methods. Who was allowed in Augustus's great trial to reshape the way things were going to be done? There would be a great need for volunteers. Conscription was for those 18 and older. Augustus was known for being more frail in his youth. This is true. Many of the time, he wouldn't go to a lot of like the battles that he was brought with his uncle Julius Caesar, because he was always sick, and that was kind of a hamper to his legitimacy. Fortunately, of course, as we saw earlier, Agrippa was a fantastic general who really, bailed him out on more than one occasion. Augustus was a great politician. But anyway, he was known for being more frail in his youth, and was suspected he had a weak heart. So he kind of opted for those like him. However, he did not want those weakened for any other reason. Most of all, Augustus wanted people who had already seen battle. Augustus knew there would be a great chance of bleeding, so allowed conscription into some legions to be open label, but was wise in that some parts were double blinded. So, how would he know, Augustus, that he had reached sufficient power in his test of strength? How would he know he achieved the appropriate power? Well, he surmised that there would be a 23% chance that people would accept a false hypothesis, giving him an estimated power of 77%, which was under his goal of 80%. But he'd take that win. Augustus also had a massive army and felt that every year, because of great leadership, he would lose no more than 1% to attrition. He felt that there was a 1 in 40 chance of people unjustly rejecting him as a true leader, alpha here in this case. And Augustus was content to knowing that if the negative effects of this trial were within 1.2 times expected, he would be considered non-inferior to the status quo. Mm-hmm. Which is pretty good because, Rome heretofore, was relatively stable until the first civil war. And not to spoil things, but after this, they'd be particularly stable for kind of a long time. Stable in quotes. So Augustus, as the new kid on the block, came out of the greatest test of his life with decreased bloodshed in his camp compared to his rival. So here we're kind of looking at the primary outcomes. Apixaban, here's the bleeding here. with the bleeding here with warfarin. Number needed to treat to avoid bleeding, 24, which is huge in terms of a number needed to treat. If you look at things like the Jupiter trial that look at, does rosuvastatin work in terms of decreasing your LDL and overall effect that has on the number needed to treat was like 20. So it's pretty close. It's about 20% off. In terms of the primary outcomes for dual antiplatelet therapy, 16.1% compared to Plavix versus placebo. So obviously you have decreased bleeding here. Number needed to harm with dual antiplatelet therapy, obviously in addition to anticoagulation, 14. Yikes. Holy moly. Don't do it. Here you go. Vitamin K, obviously warfarin with aspirin and Plavix. Primary outcome, just a bunch of bleeding. Apixaban and Plavix with the placebo, 7.3. Wow. Mamma mia. And everyone loves graphs. So here's some graphs, Wow. Obviously days, event rates. Really gets the noggin jogging. So, here's a secondary outcome. In both camps, Augustus and Marcus Antonius obviously is the leader against him. The secondary outcomes of death and battlefield wounds needing specialized treatment or hospitalization were pretty similar. Similarly, the anticoagulation choice as well as the platelet choice did not affect death too much, kind of affecting the pooling of death and hospitalizations, but mainly because of hospitalizations. In terms of the outcomes of ischemia, no real ischemic changes. Here's the good part here. Here are the effects. You have territory expansion, kind of with Augustus, specifically in the case of Armenia. He was able to negotiate a pretty sweet deal there with I think the Parthian Empire. Had to do with like recognizing the legitimacy of them, and they could install someone as ruler of their puppet, of their and Rome's puppet state, but only if Rome said it was okay. So kind of a win-win. They were able to kind of solidify borders in terms of parts of Gaul, specifically. I think it was Cisalpine Gaul. Economic prosperity. You had major reforms under Augustus, specifically under like tax collecting. Previously, Romans were notorious for just collecting taxes in terms of um, um, just leading to bidding wars and doing it. And afterwards, he had kind of a better way for doing that. Strengthening of fringe political ties, where he talked about that. Bunch of stability. Augustus was in charge for like almost 50 years or 60 years or something, I don't know. And obviously a new system that would last for several hundred years in the Pax Romana. The Augustus trial, bleed risk can be managed by bleeding people, non-hematologists, non-cardiologists. You have an expansion of their medical territory. See it here, see it here. You can save money by not spending extra on aspirin, I guess, much to the chagrin of Bayer. Stronger ties between internal medicine and the patients, increased stability, decision making, a new standard of care that will hopefully last 400 years. Look at this. This is kind of went up a little bit, but yeah. And obviously, is there any sort of big effect besides this? Yeah, you bet that there is. You have this is the American Heart Association kind of telling you how to do antithrombotic management after PCI and someone who has AFib, and they're telling you right now, essentially you don't do lower doses of a NOAC. You should really just do this DOAC, do Plavix, and Here they're saying you can contribute to 1 month, but we would stop that. And the reason they don't want to do it is because of the risk of bleeding, which is the primary outcome that we were talking about earlier. So the strategy, you can kind of read here, you should use NOAC and P2Y12 inhibitors, and most of these in the trial are Plavix. So there you go. Before going to Einstein's choice, obviously there were some issues with this trial. One of the factors is that it was open label for anticoagulation, but I guess you kind of want to let people know what they're getting into. That's really the biggest thing for me that I could tell with it. It's a pretty solid trial. Yeah. Einstein choice. So essentially, you look at kind of the risk over time of people after stopping anticoagulation. And obviously, people who have unprovoked stuff have a pretty high risk at about a year. It's maybe about 10% or so. In people who have provoked by non-surgical weight risk factors, you have to say, well, were they just laying in bed too much? Are they obese? Do they have other things going on? You look at your Padua scores, you look at your improved VTE scores, whatever. And then you've got pretty low risk people who have provoked, a VTE because of surgery. So here's what's going on here. You've got a 10% risk recurrence in the first year, people who are unprovoked after surgery. Oh, and unprovoked, yeah, after treatment ends. And that's considered to be too high. So the question is, how do 10, 20 of rivaroxaban compare with 100 milligrams of aspirin for VTE prophylaxis, and how do we look at bleeding rates? So here's who's brought in here. You have 18-year-olds, symptomatic. I'm not going to read this. You guys can obviously read this. The big thing is people who needed to be on extended anticoagulation for whatever reason were excluded, in addition to people who couldn't really be on DOACs. And again, the big question here is going to be, if you're kind of uncertain about continuing anticoagulation, who benefits? Primary outcomes, death, VTE. You looked at things like MIs, ischemic CVAs. Power was pretty good here. Here are the primary outcomes. So you go back right here, recurrent VTE and death. Pretty high on aspirin, not so much on everything else. All right. In terms of recurrence, pretty high on aspirin, not so much on everything else. And of course, this is looking at unprovoked versus provoked. And then you look at the hazard ratios. Looks like I wouldn't necessarily do aspirin. And it's kind of interesting because you look at the hazard ratio for 20 versus 10 milligrams of Xarelto, and you would say, I would consider just using 10 milligrams of Xarelto going forward in terms of primary treatment for VTE, but you can't do that because that's not what the study was looking at. And also, when they were looking at any significance, they didn't find it between the doses, which is too bad. Everyone loves graphs and images or whatever. So here's some images, here's some graphs. Pretty good. Pretty good. All right. Coming up next, Here we're looking at the bleeding outcomes, the secondary outcomes. Decreased bleeding on aspirin, but was it relevant? Not particularly. Relevant non-major bleeding. Obviously, you had more bleeding on higher dose of rivaroxaban, less on 10 milligrams, and 1.8% on aspirin. And then again, we kind of look at everything here. Looking at the secondary outcomes, you don't have a whole bunch that look statistically significant, if you ask me. So let's talk about some issues with this trial. One, you only do it for a year. The second thing is you have the International Society on Thrombosis and Hemostasis, saying that, people between 5 and 15% risk at 5 years, they would need to, not need to be anticoagulated, but you kind of go back into the original sort of thing here, and essentially you kind of fall in that little area here, but you would still require anticoagulation, or at least be considered for it, sort of by the conclusion of the trial. And here's some cool little things here, in terms of what you can do, as in the effect. You have the Dulcis trial, which I think was done in Bologna, Italy, which was looking at tracking D-dimers and unprovoked and weak-provoking factors. Things like sitting in a bed for a while, obesity. And in that case, the idea of just tracking D-dimers for when to stop anticoagulation is very reasonable. Um, so they've kind of done this sort of stuff here, which is kind of cool. But again, that's in people with like weak provoking factors and not really a whole bunch. And so you still have this question of, yeah, I can anticoagulate them, but how long am I going to anticoagulate them for? The trial is only for a year. Obviously, it's insane to do it for more than a year. So I guess clinical judgment is really the big thing. For whatever reason, if you've got someone who's sort of low risk, or intermediate risk, you can't really just use D-dimers, but maybe consider it. And then that's really it. So thank you for your time.